much delay for further session. Got it. Yeah. So, very good afternoon to everyone. I'm Dr. Nayana Mary Francis, and today I'll be dealing with you about the respiratory symptoms in palliative care. It's a very important topic for you all. Okay, let's start the class. So, first, I want you all to see this picture of our respiratory system. I just want you all to brush up your knowledge about the respiratory system. Just see the airway. Start from the nostrils, nasal cavity, reaches the nasopharynx, air reaches the larynx, trachea, and then to the bronchi, reaches the lung. Along with the lungs, we have our diaphragm and our accessory respiratory muscles, which help with respiration. So, any pathologies related to these areas will cause breathlessness. Okay, just an introduction. So, these are the three commonest symptoms we deal in palliative care in respiratory system. Among that, breathlessness is the most common one. So first, we'll be dealing with breathlessness today. So about breathlessness, it is one of the distressing symptoms the patients will suffer because it's not like pain. I think pain classes are over for you. Breathlessness is distressing because we see the patient gasping for air. And it is not only for the patient, it causes a psychosocial distress for both the family members also. They will see their relative or they will see their father, mother, brother gasping for air. That is a different situation than pain. Also, it is a difficult symptom for the professional, for both doctors and nurses for to manage it because it's not like pain. We give pain analgesics for at least some patients. The pain may come to zero, but that's not in the case of breathlessness. We can just only decrease it or like make the patient comfortable. We cannot reduce it to zero and the patient says, I'm okay, and now I'm not having breathlessness. It's not the case. We can just reduce it. We can just make the patient comfortable with our medicines. So, just telling about the definition of breathlessness by the American Thoracic Society. It defines dyspnea as a subjective experience. It means that only the patient can feel that breathlessness. Only the patient can know what breathlessness. They define it in different ways. Only per se the patient can know it. So that is what subjective experience of breathing discomfort that consists of qualitatively distinct sensation that vary in intensity. For each person, it will be different. That's what the meaning is. Okay. So about the prevalence, breathlessness is usually seen here in patients with lung cancer. Not only lung cancer, but also in patients with advanced cancer like AIDS, heart diseases, COPD, renal disease. Breathlessness was found to be more than 50%. So what I'm trying to say is it is not a rare thing. We usually see it very often, the breathlessness. Okay. So, how do the patients describe the breathlessness as? It is defined as air hunger, work or effort, tightness. What does air hunger means? Air hunger, the patient said, my breath don't satisfy me, doctor, or I'm starving for air. Some people tell like that. I'm starving for air. In some people, it will be like my breathing requires more work. It's an effort to take a breath. They'll say like that. In some patients, they say like tightness means it could be because of bronchoconstriction that is not causing inspiration. All these cause a discomfort to the patient. So there is one more thing you should know. That is, there is a cycle between breathlessness, patient, anxiety, and fear of dying. When a patient, that is, when a patient become breathless, the thing that comes to their mind first is they are going to die. Even if it us, like if we have a breathlessness, so if we have a suffocation, we are gasping for air. The first thing that will come to our mind is about death. When we think about our death, certainly we'll feel anxious. That increases the dyspnea again. So that is a cycle. Breathlessness, it is a cycle consisting of fear of death, anxiety, and dyspnea again. Death, anxiety, and dyspnea again. So it's a cycle. So this is important because there is we have a involvement both as nurses and doctors. We have a involvement in it. I'll tell about this in the treatment part. Okay. So, about the causes, usual causes of breathlessness, it includes primary or metastatic cancer, lymphatic infiltration by tumor, could be because of pleural effusion, tracheobronchial obstruction. All these are causing obstruction to the path of airway. It causes discomfort to the patient. And finally, the breathlessness. So, I'm sharing with you the other causes of breathlessness also, that is cardiac failure, angina, arrhythmias, myocardial infarctions, pulmonary causes like COPD, very common. COPD patient often come with breathlessness. At the terminal stages of COPD, patient will be severely breathless and nothing can elevate their symptoms. COPD, pneumothorax, pleural effusion, pulmonary embolism, all these causes breathlessness. And in cancer, not only lung cancer, other cancers also can cause breathlessness. How? Ascites in hepatocellular carcinoma patients mostly have ascites. They will have a big abdomen. Abdominal distension will be there, and that can cause that pushes the diaphragm, and that can cause breathlessness to the patient. Also, cachexia or respiratory muscle weakness. Cachexia causing respiratory muscle weakness. That is, these muscles, these chest muscles, helps in respiration. In cachexia, there will be muscle wasting, and these patients won't be able to breathe properly. Other things are cancer microemboli in the lung can cause a distress. Pleural effusion, massive pleural effusion causes a decreases expansion, and it in turn affects the causes discomfort. Next thing, very common, which usually happens to us also, not only to the cancer patients and those with breathlessness, anxiety, panic attacks, depression. All these are also causes of breathlessness. So now we have started. We have started our work. I just told all these things so that you may know about breathlessness and how bad it is to the patient. Now it is coming to our part. What can we do? What as a palliative care nurse or doctor can do? So first we have to begin with the assessment, a detailed and a physical examination, proper examination. So about the detailed history, first we'll take the history, and it should include certain things. Onset, when did it begin? What is the duration? How frequently does it occur? And the palliative or provocating factor. You can remember it as a mnemonic as O, P, Q, R, S, and T. So all these things you have to ask. What makes it better? What makes it worse? What is the quality? Like we discussed before, some people will think it's like I'm not getting air. There is so much effort. How they describe it, it's different for different people. Any other related symptoms? Is the breathlessness associated with cough? Are they isolated because of this breathlessness? And the severity in a scale of 10, and any treatment taken for it. All these are very helpful. We have to take it very detailed. Now we have a modified medical research council. Just go through this, just see this. It's just a scale to measure the level of breathlessness. It is a standard, it's a standard scale which is used worldwide. Okay, you can read it later. Like 0 is not trouble breathlessness except on sternest exercise. 1, 2, 3, and 4. It's a grades of breathlessness. You just need to know this. Okay. So now coming to the physical examination. See the position of the patient. She's in a propped up position. Hmm? So first itself, we have to see what and all things is happening to this patient. She has positioned herself uh, in this position so that she gets more comfortable. So first we'll start with the vitals. We have to measure the respiratory rate. We have to count the respiratory rate for 60 seconds. And then we have to do a general physical examination, which includes pyloric press, cyanosis, clubbing, lymphadenopathy, edema. So in that, cyanosis is more important and is more concerned uh, with our breathlessness than other physical signs. Positioning of the patient that is propped up, as I've showed earlier, active accessory muscles, nasal flaring, and mouth breathing. I can show you the accessory muscle wasting. In cancer cachexia, see, he has lost all his fat in his body and all his muscles have become wasted. All these muscles were helping for respiration. Now, due to cachexia, that's also wasted. And now, nasal flaring. See the difference between normal nostrils and the flat nostrils. Flat nostrils are most commonly seen in dyspnea patients. Then, now coming, so we have taken a proper physical exam, first we have taken a proper history and then we have done examination. Now we are coming to the management of this patient. How will you deal with this patient? So first thing in the management is investigations. Do we need to investigate every patient coming with breathlessness? It's a question. Actually, it depends on the severity of the disease. It's only required if it is going to alter the line of management. In palliative care, for this breathlessness patient, for every patient, there is no need to take an X-ray, hemoglobin, USG for differentiating other things. It is required according to only the physical condition of the patient. Will it help the patient by taking a patient, for example, a patient is coming to our OP with severe breathlessness. He is in end of life situation and he is having breathlessness. Will X-ray help? Will can you please do a hemoglobin will it help? No, it won't help. So otherwise, a patient coming for the first time to you and he's complaining of breathlessness, he's a cancer patient. And we need to know, in that case, we need to know whether it is because of why he's having the breathlessness. Is it because of pleural effusion? So in that patient, we can take X-ray. So it depends on the patient's condition and their life expectancy, and the thing that will it alter the line of management. So the thing you have to keep it in mind is there is no need to do X-ray or hemoglobin or USG mandatory for every patient coming with breathlessness. Okay. Now, when the treatment begins, like we are palliative care physicians and palliative care nurses, first thing we have to do, we have to ask is the wish of the patient. Sometimes the patient will have their own things. They'll tell, doctor, I'm okay with it. Sister J, I'm okay with it. And we have to ask what their concern is. Is the breathlessness really like concerning them, or is they having any other problems? We have to think about it. We have to talk with the patient. Next thing, what should come to our mind is like, will it benefit their treatment? Will he benefit? Like, will he improve after giving all these treatment? That should come to our mind. Life expectancy of the patient. That's also important. Like I said, for a patient who is going into death, a person who is going into end of life, the treatment modality and management will be totally different from the other criteria. Okay. And next thing, the decision should be made with both patient and family. And palliative care, like we usually say, patient and the family is given equal importance. Especially in breathlessness, we need to talk with them. We need to explain a lot of things to them. We should explain the cause of breathlessness if he knows, and what about the life expectancy, about like the benefits of the treatment, everything we have to explain with them. Now, like I said before, there are certain things that we can correct, which will reduce the level of breathlessness. So, management is like three things: correct the correctable, non pharmacological, and pharmacological. So, first coming to correct the correctable, what does that mean? There in these situations like in respiratory infections, pleural effusion, ascites, anemia, and heart failure, to some extent, we can correct it. Okay. Respiratory infections decreases or reduces. We give antibacterials or proper and when proper antibiotics are given. Hmm? A patient comes with you with a respiratory infection and breathlessness. You can't say that breathlessness. You have breathlessness. Nothing can be done. You are going to end of life. Nothing. We can't say like that. We can treat it. There is a treatment. It will improve with treatment. So such a condition is respiratory infection. Respiratory infection subsides with antibacterials. Next is pleural effusion. A patient with breathlessness is coming to you. Then X-ray showing pleural effusion. Can you say that you have pleural effusion? Nothing can be done. You can go back. We have only this much treatment. We can do only palliative, this thing and that thing. Not like that. For pleural effusion, we have a treatment, thoracocentesis. Not for everyone, but at least to some extent we can do thoracocentesis and patient improves with it. So that is also a solution. These are correctable measures. I hope you are understanding what the correctables means. Hmm? Then ascites. Ascites causing breathlessness. What does that mean? Ascites is pushing the diaphragm. It reduces the lung expansion. It causes the breathlessness. How can we reduce it? Tap the fluid. Paracentesis. We can do ascitic tapping. When the water comes out, at least for some time, the patient will have some kind of relief. The discomfort reduces. That is also correctable. Now, an anemic patient coming to you with breathlessness. We can do blood transfusion for him if his hemoglobin is very low. Depends on the life expectancy also. A year patient coming with the hemoglobin 6 and you can't tell that correct, it's a correctable measure. We can do a blood transfusion. Not like that. It's subjective. Okay. Then in heart failure patients, we can give diuretics. It is supportive. It's just all these are supportive measures of like to treat the breathlessness. So first we have to do correct the correctables. Rest is palliative care. Okay. Next, the non-pharmacological management. This is very important. Non-pharmacological management. This is the thing we are going to tell a patient coming to breathlessness to your OP. As sisters and doctors, you can say these things. These are some few non-pharmacological. These are not drugs, but with our words and with our actions, we can do certain things to reduce or to reduce their discomfort. So first is the calm presence of the healthcare team. Conveying empathy will relieve the anxiety. So, like I said before, a patient coming with breathlessness and they think that they are going to die now and they are anxious and they again the cycle continues. You can intervene. That's what I said before. You can say them, you can calm them down. You can say to them, don't worry, we are going to help you. This can reduce your breathlessness. So you can feel little more comfortable with that treatment. Then the fear of dying, you can address that also. Do you have that fear? Most of the patient, in my experience, I've experienced so many patients telling that after giving the drugs and after settling their breathlessness, telling that, doctor, I thought that I'm going to die. When I had breathlessness, I thought this is my end and my life is going to end. But later when they take the drugs and all, it will reduce. So the first thing is calm presence of healthcare team conveying empathy to relieve their anxiety. Next, all other things such as supportive. Few studies have shown that all by doing all these things I'm going to tell, have helped in relieving some discomfort, at least to some extent, loosening the patient's clothes. Patient wearing tight clothes, having breathlessness, when we loosen the clothes, they will feel a little relief. Nothing like it's going to like cure the breathlessness, but it helps. Okay. Using a table fan to maintain air circulation. That is what we do in our IPs here. Patients coming with breathlessness. We have small fans here. So when we use that, it will give a sensation that air circulation is maintained. It will also support it. Hmm? Then keeping room windows open, increasing the perception of space. A patient will feel more comfortable in a uh, but in a big room, not in more than in a closed room. So opening the windows or opening the doors, taking away the curtains. In for some IP patients and all, people will be surrounded by curtains on all sides. And windows will be closed and they'll be put on lights. That will all increases stress of the patient, anxiety, increases the discomfort. So by doing this, you can give them a sensation that there is increased perception of space and comfortable positioning of the patient. Like the picture showed, the proper position is the most common position this breathless people attain so that they feel comfortable. But it is not same for the all patients. For some patients, by lying side may help. Some patients with knee flex. It depends on the patient. You just try for this position. Problem. Ask whether they are comfortable. You keep in the proper position. Ask whether they are comfortable with it. You can continue that. 90% of the people will feel more comfortable, but rest 10 is subjective again. So no need to tell the patient you have to lie in this position. You will feel comfortable. You can't tell like that. It depends on the patient. Okay. And next one is modified breathing technique. First, lip breathing, open mouth breathing. Some people, even when we have stuffed nose, we usually breathe through our mouth. So that is also a good way. We can ask them to breathe through the mouth or diaphragmatic breathing by holding, by using abdominal breathing. We can ask them to. That's a modified breathing technique also. So these have to be kept in mind. These are important things. Most people won't be knowing these techniques. Hmm? So this is what we do in as a non-pharmacological management for these patients. Now coming to the bronchodilators, the medicines. First part was with our words telling you can do this, you can do that. Now coming to our drugs, what and all can help. So the first one is bronchodilators, short-acting bronchodilators and long-acting bronchodilators, salbutamol, diolin, we record, but we use steroids, small kind of steroids for nebulization. We can use it. That is a very effective. It causes bronchodilation and it helps in relieving breathlessness. Oxygen, it's not a must along with it. For some people, it will be helpful. For some, it may not be. I'll be discussing it about it later. So just know about that bronchodilators helps in bronchodilation and thereby reducing the distress. Okay, that is first one. Next one, corticosteroids. That is also very important. What we usually use in our day-to-day practice, corticosteroids. How does it work? Corticosteroids like dexamethasone. How does it work? It decreases the peri-tumor edema. There will be a tumor for those. I'm saying an example. For lung cancer patients, they'll be having masses inside the parenchyma. So around that cancer mass, there will be edema. So all these kinds of corticosteroids can decrease that edema, not to like vanish. It can totally decrease that edema, but to some extent, it will reduce edema of the airways also. So corticosteroids also helps well. So the usual dose is like 8 to 32 milligram orally. What we usually prefer here is dexamethasone. So it is given as 8 milligram or 12 milligram, anything. It depends on the patient's breathlessness severity. For severely breathless, we can give 12 mg. 16 mg, or if you don't think that the patient is not that breathless, you can give 8 mg. How is corticosteroids given? Corticosteroids are given once in a day. Once in a day, usually in the morning hours, because these kind of corticosteroids has a problem of insomnia. Patient, if we are giving this corticosteroids in the evening time, the patient won't be getting good sleep at night. So usually in the morning hours. So we started with bronchodilators, then we can give corticosteroids along with it. For example, if it is dexamethasone, 8 milligram once in a day. We can give it. We can give it for 4 to 5 days, and then taper and stop. We can't just suddenly stop the dose of corticosteroids. If the patient is taking, for example, 12 mg Dexona for next 4 days, next, we have to taper 8 mg Rexona for next 4 days. Then 4 mg Rexona for next 4 days, 2 mg, and then stop. That's only the difference. It's not like giving a paracetamol and stopping the next day. Corticosteroids should be always kept in mind. Corticosteroid should be always tapered and stopped. Okay. Now, coming to opioids. When is opioids helpful? Opioids are very helpful when the patient is having intractable dyspnea. We have tried with in such patients, we have tried with bronchodilators, we have tried with corticosteroid, but still the patient is not having any improvement. Then we'll try with opioids. And there is no other way left. There is no pleural tapping, there is no ascitic tapping, nothing can be done. Patient is there with breathlessness. We are not able to manage him with our bronchodilators. We will go for opioids, morphine. Hmm? So, how does people will come and ask for as a palliative care nurse, you are dealing with such a breathlessness of a patient, and you are asking them to take opioids, and somebody comes and asks you, sister, how is it? How does it work? In that case, you should know these points. These are the points which should be kept in your mind. Why we use opioids in breathlessness? So, first one is intractable dyspnea. Nothing works. Again, there is no solution. Patient is having breathlessness. We'll start on with opioid. So, how to be safe and effective also, reduces inappropriate and excessive respiratory drive. Slow down the respiratory rate. Morphine reduces the respiratory rate. So, but thereby the patient with breathlessness, it will be tachypnea, it will be 30, 40, 50. So, morphine helps in reducing the respiratory rate. Also, it reduces excessive respiratory drive. The patient will not feel like too much effort is there. Decreases the effort of breathlessness. Breathing is made more efficient and sensation of breathlessness is reduced. That is very important. Breathing is made more efficient and sensation of breathlessness is reduced. Okay, these are the points that should be kept in your mind. Okay, now we are going to prescribe medicine, prescribe morphine for breathlessness patient. So how we usually start is the lower dose. We usually start with 2.5 mg or 5 milligram Q6 saline. Usually, from your other classes, you would have understood that we usually for pain patients we start morphine in the dose of 5 milligram. So in respiratory patients, the dose required is less than required for pain. So there we start with 5 milligram. For breathlessness patient, we start with 2.5 milligram. It can be increased. Nothing like you can't increase the dose. You can increase, but the starting dose is 2.5. 2.5 Q6 tally. Later, we can increase the dose and increase up to 5 milligram Q6 tally. If you want to increase it again, you can increase it. Depends on the patient's improvement. The thing is only the thing opioid dose required for breathlessness is usually less than required for pain. This point also you should keep in mind. Okay. So this page is very important. You have to keep this in mind. Takeaway points are there in this one. Okay. Then, if a patient is already on morphine for pain, and then the patient develops breathlessness, we can hike the dose up to 50%. That is also there. A patient having ascites, hepatocellular carcinoma, he was having pain in the abdomen, and he was taking morphine as 5 milligram Q4 tally. Okay, I'm telling an example. Hmm? Patient with hepatocellular carcinoma, patient having pain, is already on morphine 5 milligram. He develops breathlessness due to the ascites. Tapping is not possible. Patient is in EOL, end of life. We can't do anything. We need to control the breathlessness. So what we do is, patient, it's already on morphine. The last point, I'm trying to explain the last point. And so 50%, we'll increase it by 2.5. That is, we'll make it as 7.5. Patient was already on 5 milligrams. We increase it as 7.5. Okay. These are the things with opioids. So now we have tried what? Bronchodilators. We have tried corticosteroids. We have tried morphine. We have tried opioids. Then also patient is not settling. Patient is still having anxiety. Patient is breathless. Patient is having breathlessness. What will we do? To relieve the anxiety, we give benzodiazepines. Lorazepam, diazepam, midazolam. All these are benzodiazepines. So what we actually try to do, they are not, benzodiazepine are not a first line agents. Patient coming with breathlessness, you can't give midazolam and sit. He's restless, we can give midazolam. We can't do like that. We have to settle him with opioids. If not, nothing is working, we can give benzodiazepines to settle the anxiety. Okay? So it should be kept in mind they are not like first line agents. They're just helping to relieve the anxiety. And we can either give lorazepam 0.5 mg sublingually or 1 mg sublingually. The lorazepam is long acting. Midazolam, short acting drug, we can give for 1 or 2 milligram IV or subcutaneous. Depends on the situation of the patient. Now, important thing is a trial of oxygen. Not every patient in palliative care requires oxygen, those with breathlessness. We usually face this scenario like in our day-to-day life. We have patients coming here. Patient will be admitted in ICU. Patient will be a CA patient having breathlessness. Patient will be on oxygen support coming for palliative care. So we have to make them understand that oxygen is just a supportive measure. Not every patient will benefit from oxygen. So what we do is we give a trial of oxygen. For some patients, this oxygen, by giving oxygen, it will help to improve their discomfort. But in some cases, with terminal cancer, terminal breathlessness, oxygen may not help, but it will become a discomfort for them. Keeping a face mask, keeping a nasal cannula, giving continuously oxygen, which is not helping in anything. Is it required? No. So we will talk with the family about this. Patient coming to breathlessness, most of the patients will be in oxygen. We have to talk with them. We have to make them understand this point. We can give oxygen trial. We can see how it works. If the patient is improving, we can give. If the patient is benefiting from it, if the patient says that, yeah, I'm little comfortable with this, you can continue. But if it is not helping, it is not required. So that is a point. You can, one more thing is, you can, for those patients who are benefiting from oxygen, you can use nasal cannula. Other than the face mask, which can cause sense of suffocation. So better to use a cannula. And if it is not helping, you have to talk with the caregivers. Prior explanation to the family is required to avoid misunderstanding when oxygen therapy is discontinued. That is very important. Okay? You can't like go and stop oxygen. It's not helping. We are going to stop oxygen. You'll get beating sometime. So that needs to be explained. This is what we do in palliative care. If it is helping, we'll continue. We have oxygen concentrators, we have oxygen cylinders. And house also, if the patient is like benefiting, we can give this thing. I can give what concentrators at home. Otherwise, we can leave the patient. We can give morphine. We can explain the family that it will not help. Morphine, otherwise morphine will help. There are other drugs which helps. We can see that. It is based on your communication. You have to communicate that. Okay. Thank you. And these are the things that you should keep in mind. So the first part, the summarizing. The first part was about the assessment you have to take, like the history, what it is, what the patient is feeling, and the things you get from the patient. The second part was regarding how and what you can do as a palliative care nurse or a palliative care doctor. How can we treat them? How can we manage the situation? Okay, that's all. Thank you.
Thank you, Dr. Nayana. That was a very comprehensive presentation. So, since we have completed the session in time, like if there are any pressing questions regarding the session topic, we can take it up before moving to the case presentation. Any queries, any comments, any real life experiences which you would like to share before we take up the case for the day? So, Doctor, I believe they might take some time to at least, yes, we do have a query coming up in the chat box.
We prescribe morphine for breathlessness or other pain that the patient might have.
Michael, would you like to unmute yourself and throw some more light on your query?
Okay, I wanted to understand that normally morphine we prescribe it for pain, but I was wondering if we give it for somebody who is having difficulty breathing. What's the scientific rationale behind that?
It's not like we give morphine for all patients in pain. We'll manage, it's according to the disease also and the severity of the disease. For example, a patient having a fracture and and he's having pain. We can't give morphine. We try with all the analgesics we have, what NSAIDs, and that will help. If it is not helping, and if the patient is having like that, usually doesn't happen with a fracture. I'm telling an example. But if it is an uncontrolled pain, if it is a chronic pain which is disturbing him, and if he's not having any relief with any other medicines, and he's suffering so much, and according to the scale, the pain is that severe, we give it. For example, we get so many patients from surgery department, peripheral obstructive vascular disorders, patient with ischemic limbs, comes with pain. The pain sometimes it won't be controlled with all those medications and all. Then we will prescribe morphine for them also if the pain is not controlled. Calcific pancreatitis. Like I'm telling all the examples. Other like not in cancer, other pains. Chronic calcific pancreatitis patients come with severe pain. It is not controlled with the tramadol injection, what we usually give in hospital setup. If the pain is that severe, according to a scale, if it is more than 7 or 8, and if it is not improving it with any other medications, we give morphine. Thank you for the question, Michael.
Thank you, Dr. Nayana. Dr. Michael, I believe that answers your query. Okay. If anyone else is not having any immediate questions which need attention, I think we can move on to the case presentation of the day. Sister Sarah?
Yes, thank you. I will be presenting today on behalf of myself and Ms. Anita Barman. We are nurses and we work in a LEM hospital in Bangladesh. So I will be presenting on this patient, and but Anita has more details regarding the patient's condition. So if you have any questions, she will be the best one to answer them, but I will present. So this is a female patient, age 68 years old, diagnosed with tuberculosis, pleural effusion in her right lung, and also a mass was noted on her right breast on admission. So she presented to our hospital with low-grade fever for 2 months. She had shortness of breath for 5 to 6 days, as well as a hoarse voice, and she was having some difficulty speaking. So for the past 2 months, this patient had worsening symptoms with fever and shortness of breath. She was admitted in October for significant worsening of symptoms over the past couple of days. She had increased fever, shortness of breath, and hoarseness of voice. So during the hospital admission, the doctors noted a 2-centimeter right-sided breast mass with a superior vena cava obstruction. And the patient herself had not noticed this mass before at home. Both of her breasts were enlarged and swollen, and she had not had any outside examinations or biopsy done at another hospital. So on admission, on a presentation to the hospital, the patient appeared thin and malnourished. Her voice was hoarse, so she had difficulty speaking, and it was difficult to understand her as she was telling her disease history. Vital signs, her blood pressure was 110/80, pulse was 80, oxygen was 88% on 2 liters, respiratory rate was 30, and her temperature wasn't written here, but she had a low-grade fever of about 100.3. So her lung sounds were diminished on both sides, but on the right side, extremely so. Her right lung had firmness and dullness on palpitation. So they did a chest X-ray, right side pleural effusions with massive lung collapse. And so during her October admission, she had a 2-liter pleural tap done. Both of her breasts were enlarged, and as said before, 2-centimeter mass was noted on the right breast, and a surgical consultation was recommended. So during the hospital admission, we did a chest X-ray. She was given oxygen and medications for tuberculosis. Pleural synthesis was done. However, our surgeon at this time was not able to evaluate her breast mass. So medications she was on during her hospital admission: anti-TB medication for FDC, paroxetine, she received salbutamol inhalers, and paracetamol to manage her fever. So regarding her social history, the patient has 1 son who's a farmer. The patient was a widow. Her husband had died. The patient's son is a farmer and day laborer. He is married and has children. Patient and the son did not go to school, and they are poor. Everyone in the household is busy with work and school, so it is difficult to care for their mother and grandmother. Also, their house is not very clean. So our primary concerns we identified: progressing tuberculosis illness, possible breast cancer with lung metastasis, or at least affecting breathing, financial stressors, as well as caregiving and environmental stressors. Patient is in a dirty home environment and is somewhat neglected by family. So just to summarize, the patient is a 68-year-old widowed female with progressing tuberculosis and possible breast tumor. She was admitted to the hospital in October, now at home and receiving visits there from our palliative care team. Although the patient has since died, we just found out. So since we made this presentation, the patient unfortunately passed away, but we can still discuss the patient and management of her condition. So discussion points. So Surgical consultation is needed for her breast mass, possible outside biopsy if finances permit. So our hospital is in a rural setting and there's not, we can't process biopsies. We can do biopsies, but they need to be processed outside. So there's some limits as to what diagnostics we can do, investigations we can do. So how can her respiratory symptoms be managed? Is the inhaler working for her? Are there other meds like steroids needed? Is oxygen at home possible for her if that's needed? Also, how can she comfortably be cared for at home? Patient is often sitting up, she needs extra pillows. Are there things that could be done to make her environment more comfortable for her? Also, are there other social supports who can help with her care, like perhaps daughter-in-law, neighbors, other family members, so that she won't be isolated and perhaps her environment could be made more livable. Okay, thank you very much.
Thank you, Sister Sarah, for bringing in that very elaborate case presentation, I suppose. So now it is the turn of our participants. If this case had come to your setting, what would be your observations and how would you have managed it? Right, Doctor?
That's a nice case, and it's sad that the patient has expired already, right?
Yes.
Yeah, okay. So about the first question, the surgical consultation needed for breast mass possible outside biopsy finances permit. So I can't tell like a clear-cut thing because it depends on in this case, it depends on the patient's condition. Actually, there are certain factors which are correctable in this. The patient is having tuberculosis. We can give ATTs. Symptomatically, she was having pleural effusion, which is also correctable to a mild extent. Because we can do tapping thoracocentesis for the patient. Patient would have improved a little more. Also, I have a concern with the breast mass. Actually, we don't know whether it is a malignancy or not. So I would go for the biopsy and to find whether it is really a cancer mass. The breast mass could be anything. A patient having fibroadenoma might be having TB also. So I need to I need to do a biopsy for this patient. And if it is a metastasis, my line of management would be different.
Right.
Okay, so that from my class, I think the points we can do here is correctable is there. There is an underlying infection, TB. We can correct it. Pleural effusion. We can do thoracocentesis. And if it is not working, we can go for the non-pharmacological and pharmacological methods for her. Okay. Then the next question, like how can her respiratory symptoms be managed? Okay. That is like first thing is pleural tapping in this patient. Pleural tapping would have been very much important for that. Also, we can give corticosteroids for those patients. And inhaler, it depends on the patient. Some patients with pleural effusion responds to kind of inhalers, nebulizers with like salbutamol, with budesonide, corticosteroid. If it is, it was that is up to the patient. If he was feeling relief with it, we need to have to continue it. Then you have also mentioned that superior vena cava obstruction. So I think that class is over for you. That's an emergency. In emergency palliative care, it needs emergency attention, and that is also managed by corticosteroids, dexamethasone, hydrocortisone, all kinds of corticosteroids. So I think it would have managed like that. And if it was not responding to corticosteroids and dilators, then definitely we should have started around morphine, 2.5 mg, either Q6 Hali as a TDS or like BD, depending on the improvement of the patient. Now, the next question is like, how can she comfortably care for at home? Like I said, all those empathizing words, like to relieve their anxiety, telling them that you are not going to die soon. Like not like that, but it is not the end. Some people will be thinking like that. I told you, no. So that one. Oxygen support in house settings, we can use oxygen concentrators. We can use concentrated at home. We can deliver up to 6 liters of oxygen. It will be also helping. And all those medicines to be continued, oral medicines, all these medicines which I have told, there are oral tablets also that we can give, that can be given at home and managed accordingly. Then, are there other social support who can help with the care? Everyone can help. That's what I can say. That's all. Any questions?
Sister Priya suggests as FNAC critical.
Yeah, FNAC can be done, FNAC or biopsy. To know what type of cell it is, what type of cancer it is. Because the chemotherapy depends on the FNAC, like what report is coming.
And Sister Mukisa has brought out a very relevant point. Sensitization on use of mask by caretakers to prevent, I believe, it was TB from spreading.
Okay. Any questions to be asked?
Any points to be shared?
Have you come across any situations with a breathless patient? Anyone wants to share? I think we have little more
I have a
time.
question.
Yes.
Uh, should our patient put on a mask to prevent TB from spreading, or how do we do that? How do we prevent TB from spreading now?
Sorry, can you just repeat it once again?
How do we prevent TB from spreading since our patient has TB? Do we give the mask to the patient or the caretakers? What do we do with that?
I think the audio is not that clear. I'm not getting what
Were
you're
you
saying.
saying about the masks, Brother Mukisa?
Yes, a face mask.
Yes. You wanted to know whether we give the mask to the patient or the caregiver or to both to prevent the spread. If I got you correctly?
Yes.
Yes. So he wants to know, since we were mentioning about a patient with TB, Brother Mukisa wants to know, to prevent the spread of TB, which is more efficient, to give the mask to the patient himself or herself, or the caregiver, or to both.
I would suggest to both. It will be a double protection, both from the patient and for the caregiver. It increases the efficiency.
Okay.
A person wearing mask, we cannot like 100% tell that the infection is not coming out. It is only just 50. The rest 50 is by when the caregivers wear the mask.
So I believe not only the TB virus, but overall any respiratory ailment from spread, to prevent it from spreading, maybe the two, or the two, both the parties should be wearing the mask.
Yeah.
Okay, Sister Sushma wants to know, could we use any nebulization? Is it use any nebulization for this type of patients?
Yes, of course, salbutamol nebulization, levosalbutamol, Stalin nebulizations will help. Steroid nebulizations will help. Budesonide, what we usually use here, it will help. We give all those nebulization as Q6 Tali or Q8 Tali. We give it. Sometimes this nebulizations will be along with the oxygen support. For some patients it will be helpful. And even if the patient is taking QA early and sometimes the patient develop breathlessness, we give it as SOS. At that time, we give one nebulization. They will feel better. At night time, usually, though these patients with breathlessness, they will have some kind of exacerbations. So nebulization is a very big blessing. At that time, we can give nebulization. If it is not settling, we'll go for SOS morphine or something like that. Nebulization is a very good method.
Mm.
Yeah, that is needs to explain regarding proper hygiene of the patient and surrounding. That is also very important, not only in the case of breathlessness, in case of every disease, hygiene is a concern. BiPAP machine, it's not commonly used. We usually follow these methods. We try for all these pharmacological methods, and only if it is not this thing, BiPAP is. I don't think we usually don't use it here. BiPAPs. We are not trying to revive the patient using BiPAPs. We are just supporting them just to ease their discomfort.
So I do have one more question, not about this case in particular, but just generally about the use of morphine. And I'll give an example. One of my first palliative patients that I ever had in the hospital setting, she was comfort measures only, which is the status that we put on patients when we think they're going to die within hours or days. So I had this patient as a new nurse with respiratory symptoms, and her respiratory symptoms were getting worse. And my manager suggested, I think, she has morphine prescribed PRN as needed. So why don't you give her a little bit of morphine? So I did. And then I checked on the patient 10 minutes later, and the patient had expired. So that was pretty distressing for me as a new nurse. I thought, oh no, I hastened her death. And now looking back on that, I realize, no, my job was to take care of her and to relieve her symptoms. And as you have mentioned, the goal of palliative care, we don't try to hasten death, but we also don't try to prevent it. So I just think with using morphine, we need to sort of understand and be prepared for that might, because morphine depresses the respiratory system, that the patient could possibly expire sooner. But how do we prepare the family members for that so that they're not very alarmed?
Okay, that was a nice question. Actually, what I have to say about this is there is no proof that morphine hastens death. It could be because of the natural or his or her general condition. What thing you should keep it in mind is like all our breathlessness patients, CA lung or all kind of CA liver patients with breathlessness, they eventually passed away. The thing we can do is like when they are living, when they are at that moment of breathlessness, when they are breathless, we can just make them comfort with morphine. That is the thing we should keep in mind. I don't like, it's not good to think like that. Okay. Don't think like that. It will hasten the death. We need to properly tell to the caregiver about the poor prognosis of the patient and what we are going to do. We are going to support her. We are going to reduce her effort of breathlessness or pain. Okay? Okay. Thank you. And that is one more thing I have to add. That is like a false conception that after giving morphine, the patient will die soon. Even some caregivers will ask, oh, when we tell that we are going to start morphine, oh, so the patient is going to die soon. It is not like that. Just make them understand that this is going to help your relative, or this is going to help your father, brother, anyone to alleviate their symptom. That's all. Okay.
Is any one of the participants just anxious, just like me, to know how the non-pharmacological management was there in this particular case, or any case to be in general? Like being a non-medical person, I always take interest in knowing more about the non-pharmacological interventions if we could. So if any one of you are anxious to know, maybe I could request our doctor to throw some light on those as well.
Okay. Actually, what you said is right. Even as medical professionals, we are not aware of. I was not aware of it after coming to here only. After attending the course only, I came to know about this one. But it is helpful in our day-to-day life. I have experienced so many cases. This non-pharmacological techniques have a big role in relieving their distress. It's a surprise.
And a vast topic as well, right?
Yeah.
So we had one question. Sister Sujita wants to know: is any breathing exercise? Does any breathing exercise helps in
Yeah, it can.
reducing?
All those kinds of, in some patients with COPD patients having severe cough, cupping exercises, chest physio. It can just relieve their symptoms. Nothing like it will reduce like a physiotherapy, but we can just give it as a supportive treatment. Cupping, physio cupping, chest physio. That's all.
Yes, Sister Harita was commenting, provide comfortable position to the patient. Definitely, is
Yeah.
that is a very useful non-pharmacological approach.
Spirometer, we usually don't recommend that. Can be helpful, but I don't think that will help much. It will be a difficulty for the patient. It is usually helpful for those post-surgical patients who has undergone surgeries, those with fibrosis to increase the lung capacity. But in CA patients and cancer patients, that is not the cause of their distress. So it won't be much helpful. There will be a tumor pushing, like causing an obstruction to the airway, or there will be pleural effusion causing respiratory distress. So by doing a spirometry, it won't help much. Hope you all understood what I've told.
We do have a couple of minutes more left in case you have any further queries or suggestions or points to be brought in. Or else we can move to our teacups a little bit earlier. So I think that brings us is the thank you messages have started coming in. So that brings us to the end of another wonderful session. I believe this at least one point you all could take home as a new learning point from today's session. So with that positive hope, this is Sripriya along with Dr. Nayana Mary Francis signing off from the Tips Eco Hub. Everyone take care till the next session. Take care. Bye-bye.
Bye bye. See you.